Welcome to the Motivational Midwife. My name's Lynn Jones, and today we're going to look at examination of the placenta. So we'll have a little look at what we do to examine the placenta. So why are we examining the placenta? Well, firstly, to ensure there are no abnormalities. And secondly, we're ensuring that it's complete, because any part of the placenta that's been left behind in the uterus is going to impact on the uterus's ability to really contract down and control the bleeding. And thirdly, we're excluding signs of infection there that might need further investigation, either for the mother or the baby. So things that you might need to consider: obviously this will have body fluids on it, it has blood on it, and likewise, so you need to be wearing your universal precautions, so pinny and gloves, and have a nice flat surface with good lighting so that you can examine well. It is important that it's done thoroughly and not just rushed, because it's quite easy to miss things if you're rushing. So firstly, have a look at the placenta. Does it look the size you would be expecting? I mean, a placenta, roughly, we don't weigh them anymore routinely like we used to years ago, but generally the placenta is about 1/6 of the weight of the baby. So if you've got quite a big baby, you're expecting a fairly big placenta. But if you've got a little baby and a big placenta, you might be thinking, oh, what's not right there? The colour of it, does it look a nice healthy colour, a nice pinky red colour, or does it look pale? Does it look unhealthy? The shape of it, the thickness of it, and is there any offensive smell from it? Does it smell like there's perhaps evidence of chorioamnionitis? So looking at the fetal surface first, I mean, what a lot of people do is actually hold the placenta up by the cord and have a hand underneath on the fetal side, no, maternal side of the placenta, and let the membranes hang down. So you're examining, do the membranes look complete? Can you see a nice neat hole where the membranes have ruptured, or where they've been ruptured with an amni hook? You really need to try and piece everything together to make sure they are complete, because, as I say, anything that is left behind, even a little bit of membrane, can impede the uterus's ability to really contract down and put that woman at risk of a postpartum hemorrhage. So look at the fetal side. Where is the cord inserted? For most, it will be central, so it'll be in the middle. And the cord length, we don't measure them anymore, but an average cord is about 50 centimeters long. Is there, is it a nice thick cord, or is it very thin and scraggly? Has it got lots of Wharton's jelly in there? Have a look at the vessels to make sure we have 2 arteries and 1 vein. If there is only 1 artery, then that is sometimes associated with renal agenesis, so absence of kidneys. So you would watch that baby very closely for urination to make sure that it has urinated, but you would also highlight that to the paediatricians, the neonatologists, to make sure that baby's had a thorough examination and some follow-up if required. Are there any knots in the cord? You tend to get knots with babies that are very active. My 3rd child had a true knot in the cord, and twice around her neck actually. So she was always on the go in utero, and pretty much after she was born, pretty much the same. Then moving on to the maternal surface. So all of this is a nice healthy looking colour. You can see all these little bits that look like they're joined together. They're called cotyledon, these lobes, each lobe, they're called cotyledons. And you're making sure that they kind of all fit together. Often when you've put the placenta on your flat surface, it all sort of falls apart slightly, and it can look, particularly areas like here, can look like there's a little bit missing. So you need to gently fit it all together and see, is there actually a piece missing, or is it just the way the placenta's been lying? So does it look complete? Are there any extra lobes, or what we call succinturiate lobes? And a succinturiate lobe really is where a small piece of the placenta has separated from the main body of the placenta, and it's kind of formed an extra lobe. Some of the villi have gone into the chorionic membrane, and they just create their own little extra lobe there. So when you're examining the membranes, if you see vessels going into the membranes, but then there's a hole at the end of those vessels, it's possible that there has been a succinturiate lobe there, and that is still inside. So it is important that you really track any vessels that are going into the membranes to their end point and see that there isn't a lobe actually missing. Looking at how does it feel? So run your fingers across it. It can feel quite gritty, and that's really particularly evident with post-mature placentas. They become quite calcified, and it can appear as sort of grey, whitey, gritty patches, and it feels quite gritty. And really, it's there's not much significance to the post-mature ones. You might see and feel sort of red and white patches. They're called infarcts. They start red and then they become whiter and fibrous tissues. And these are really areas of the placenta that have essentially either had no blood supply or poor blood supply, and the tissue has died. You often see that actually with preeclampsia. You will often see quite a lot of infarcts on women who've had preeclampsia and poor blood supply to the placenta. So here's our little cord here, and I've just done the colours blue and red because if you remember 2 blue eyes and 1 red mouth, then that will remind you that the less well oxygenated blood is actually in the arteries, and the oxygenated blood is in the vein, which of course, apart from your pulmonary artery and vein, is the only other place in the body where it's that way around. Usually arteries carry the oxygenated blood and veins carry the less well oxygenated blood. So looking at your cord insertions here, then circumvallate and circummarginate, these really are where the chorion hasn't really attached itself to the it's not attached to the edge of the placenta but to the fetal surface, quite a distance from the edge, and it forms a sort of thickened ring. So you can see it really quite well here, and here it's not quite so, it's a little bit further in. You can have a bipartite placenta, or sometimes known as bilobed. So, and that's this one here. So there's kind of 2 distinct lobes with the cords still central. This is the succinturiate lobe we were talking about earlier. So you can see those 2 vessels coming off the main placenta and the little lobe at the end there. So if you were examining the membranes and you could see those 2 vessels, but there was a hole here, then you would be fairly suspicious that there was a succinturate lobe that had been left behind. And if you have the insertion of the cord at the edge of the placenta, it's often called a battledore insertion. And these are just points to really be mindful of. The velamentous insertion, this is where the blood vessels are actually inserted into the membranes. They go through the membranes into the placenta, and you very often don't know that until the placenta is delivered. But if you get any bleeding, particularly after membranes have ruptured, then alarm bells should be ringing in your head in respect of vasa previa or velamentous insertion of those. So hold the placenta up by its cord, as I've said. Observe those membranes. Do they seem to be matching? Put your placenta on a nice flat surface. Have good lighting so you can really look at it well, and peel back both the amnion and the chorion. Peel it right back to the cord base so you can be certain you have got actually two membranes there. And then record your findings within whatever your trust system is, be it electronic or handwritten notes, and making sure that you record exactly what you found. So for most it will be that there's 3 vessels and 2 membranes, and that everything is complete. But if you're finding anything, signs of infarction or offensive, if it's offensive, you might want to take some swabs of the placenta and just send them off for culturing and seeing if there is any infection on there. And then importantly, it's very important that you dispose of it. This is human tissue, so it has to be disposed of correctly. Often that will mean double bagging and into a specific container for placentas, and they are usually incinerated. Now, interesting fact, which many of you may or may not know, that back in the day when I trained, hospitals used to sell placentas, and I think they used to get about a penny a placenta. And we had a huge freezer in the sleuth room where all the placentas just used to go. They didn't have to be bagged or anything. They just literally went in this freezer, and companies would, cosmetic companies would buy those placentas because they would extract the hormones from the placentas and they'd go into your lovely face creams. The advent of HIV meant that wasn't really ethical anymore, so they stopped doing it. You may find that some women want to keep their placenta. So I lost my train of thought there. And if that is the case, then you really need to be following your trust's guidance on making sure that the family have the correct information as to safe disposal of that placenta. There are quite strict rules about it because it is human tissue, so you can't just sort of chuck it in the bin with the waste. And some women will take their placenta and have it encapsulated. There is some evidence which would suggest that having your placenta dried and turned into capsules staves off postnatal depression. It's quite an interesting subject to read around. And there you have it, examination of the placenta. I hope you found it useful. If you haven't subscribed to the channel, please do so, and look for us on Facebook at The Motivational Midwife. I look forward to seeing you next time.